I I appreciate it. My name is Drew. For those of you who don't know me, I am one of the infectious diseases pharmacists here at WVU Medicine, Ruby Memorial Hospital. Myself, along with Dr. Juskowich, are kind of going to give a brief overview of our what we define and how we implement antimicrobial stewardship, OPAT, and COPAT here at our, not just our facility, but in some different institutions and locations around our health system in the state, just to kind of get a gauge of an understanding of what all these different acronyms mean and how we implement these programs here locally and across the system. So today, at least for my portion, we'll define antimicrobial stewardship and outpatient parenteral antimicrobial therapy, as well as talk a little bit about COPAT and how it overlaps in a brief case that I was going to present just to demonstrate how these services all work together. And then that's going to be the second objective, to how they intertwine and provide the best patient care across our the entire patient care continuum. So typically the first, at least from our end, I'm a pharmacist that works across all three of these services, and often they're initially identified on one of our antimicrobial stewardship lists that we look at here locally. And then should they require further treatment with OPAT, with antimicrobials at discharge, they might then be covered and followed by either our OPAT or our COPAT programs, wherever they're discharged to. That could be home, that could be to a nursing facility, an LTAC, really anywhere outside of our hospital at discharge. First, looking at antimicrobial stewardship, the definition of stewardship is the job of supervising or taking care of something. And IDSA SHE identifies specifically antimicrobial stewardship as coordinated interventions designed to improve and measure appropriate use of antibiotic or antimicrobial agents by promoting the optimal drug regimen, including dose, duration, and route of administration. So when I think of antimicrobial stewardship, picking the right antimicrobial for the right bug at the right dose and route for the right duration is really what I think it's all about, and ensuring the appropriate use of all antimicrobials. Myself and a lot of us here, other pharmacists I work with at Ruby, like to promote the idea that everyone is an antimicrobial steward. So it's not just practitioners that are involved with day-to-day care of patients on antibacterials. It could be providers in urgent cares, outpatient clinics, those who might see patients in an emergency department, those who round on patients internally within a hospital. Everyone can apply the principles of antimicrobial stewardship to their patient care. Why do we need this? Some studies have indicated that up to 50% of antibiotics that are prescribed are suboptimal. So that doesn't necessarily mean antibiotics aren't indicated in those cases, but something about their prescribing or dosing, or specifically the antimicrobial picked, could be slightly below what we would identify as optimal for a patient. Misuse of antibiotics can cause a number of unfavorable outcomes. It's another reason why we like to steward them closely. This could be things like Clostridioides difficile or C. diff infection, and the breeding, and provide the breeding ground for multi-drug resistant organisms, which we want to avoid. So we ensure that we have enough antimicrobials available for any future infections a patient may have, or the population as a whole. So our goals in stewardship are to both promote patient safety, optimize our resource utilization, and prevent the development of antimicrobial resistance here at WVU. These next couple of charts are just going to show you why we take stewardship so seriously here throughout WVU Medicine. You can see the outpatient antibiotic prescription rate in West Virginia, granted this is now a couple years old, from 2021, is 1,022 prescriptions for every 1,000 patients. So that is over a prescription per individual in the state of West Virginia. And unfortunately, that's ranked second in the country as of 2021, along with a number of other states kind of in the southeast of the United States have high outpatient rates of antibiotic prescription. And we also rank higher across the country in inpatient antibiotic use relative to both neighboring states and across the country. This particular graph is showing our SAR value. It's just a value created by a value created to essentially measure and compare the use of antimicrobials to other hospitals and institutions across the country. And our value is slightly higher, or actually quite a bit higher than that of the national median SAR value, indicating higher antimicrobial use in our hospitals in West Virginia than throughout the nation. Not only that, but antimicrobial stewardship specifically is a best practice and required for accreditation by the Joint Commission, which accredits a lot of our hospitals and facilities across the country. Not only that, in 2015, a national action plan for combating antibiotic resistance was implemented by the executive branch of the United States, and IDSA and SHEA have published their own guidelines for implementing an antibiotic stewardship program. I'll spend a little bit of time on both the core elements highlighted by the CDC and the Joint Commission on establishing stewardship programs, but antimicrobial stewardship should not just encompass the hospital settings, also small and critical access hospitals, outpatient facilities, nursing homes, other resource limited facilities. In addition to those CDC core elements, the Joint Commission has implemented, as of January 2023, 10 elements of performance that all hospitals who are assessed by the Joint Commission are assessed by. And those, it's in small text here, but there are things like having dedicated leaders for a stewardship program, allocating adequate financial resources for stewardship, multidisciplinary committees for overseeing antimicrobial stewardship, just to name a few. Just talk a little bit about those. I wanted to briefly talk about how we go about stewarding from our pharmacist workflow perspective here at WVU. Stewardship programs can take on many different forms and across different hospitals, but this is how we typically identify opportunities for inpatient antimicrobial stewardship by using this tiered approach. And it's essentially ranking different scenarios in which we feel need intervention or additional eyes on patients whenever they're here at our hospital. So some of the most important things that we like to review are cases of positive blood cultures, the results of rapid bloodstream diagnostics, and anything that's identified by our electronic medical record software as a bug-drug mismatch, in which a patient might be receiving an antimicrobial that doesn't adequately cover the organism they're growing. We also look at things like the use of broad-spectrum antibiotics, opportunities to de-escalate antibiotics and other antimicrobials. And in tier 3 are things like specific pathogen reviews, where we would review things like Pseudomonas aeruginosa, other nosocomial pathogens for optimization of treatment there. This is a patient case I wanted to briefly present. This is the kind of showing you how at our facility, all 3 of our services can overlap. So this is a 51-year-old male admitted for necrotizing fasciitis. They have an MSSA bloodstream infection that's identified in these blood cultures. Initially, we're started with vancomycin, zosyn, and clindamycin. The AMS pharmacist who looked at this specific alert, so they were alerted at our facility because they had a positive blood culture, had recommended we target MSSA with IV cefazolin and repeat blood cultures, and recommended to get our ID consult involved. So that's kind of the first piece of antimicrobial stewardship being involved in the patient's care. After in the hospital for a while, ID Consult has seen them, and they had recommended a total duration 4-week treatment course for this MSSA bacteremia, in addition to finding a gas-producing skin soft tissue infection and a diabetic foot infection with 2 weeks of outpatient IV cefazolin, followed by 2 weeks of oral cefadroxil for their last 2 weeks of therapy. So in this case, we followed this patient both as part of our OPAT and COPAT services. So they were actually discharged to a skilled nursing facility where our OPAT service comprised a number of pharmacists here at our at our hospital and a dedicated OPAT position for a couple of weeks. And then our pharmacist and physician with COPAT followed the patient for the remainder of their treatment course. At WVU Medicine, like I mentioned earlier, OPAT stands for Outpatient Parenteral Antimicrobial Therapy. Our goal with OPAT is to ensure all patients who are discharged on IV antimicrobials complete that treatment safely and effectively. Here at WVU Medicine Ruby, it was first established in 2017 and was comprised of a single ID physician, Dr. Nasser Roydad, and one of our ID pharmacists, Dr. Mira Mehta, back in 2017. This is just showing you through the need and the growth of the program, it's now grown to a dedicated ID physician in Dr. Johnson. We have an OPAT nurse dedicated to our OPAT patients and an administrative assistant, and up to 6 ID pharmacists who could be involved in the patient's care with monitoring patients on OPAT. I won't linger on our headshots for too long, but that's just it shows you how much our team has grown over the past 8 years or so. We average around 1,500 consults to OPAT per year, and since the program's inception in 2017, have seen and followed over 10,000 patients. We follow patients both here in West Virginia and the neighboring states like Ohio, Pennsylvania, Virginia, Maryland. And we've helped develop OPAT programs across the entirety of across the United States. People have reached out to us to identify how they should build an OPAT program that works effectively. Again, as an OPAT program, we often coordinate with home health agencies and home infusion companies regarding antibiotic infusion at the home. We'll communicate via a variety of different ways. So often talking directly with patients, communicating via messaging services to different physicians to make sure that patients get the optimal IV therapy. So through our journey here, the OPAT team follows the patient all the way until they finish IV antimicrobials and are due to have a line removed. A lot of these patients on OPAT are discharged with like a PICC line or a midline for IV antibiotic administration. Our OPAT team will follow them for lab results, ensure their infections clinically resolving, all the way until they're due to have their PICC line or midline removed. Lastly, just to give you an idea of where OPAT is involved. So this is an intentionally busy slide to show you that we follow patients through a number of different SNFs and long-term care facilities throughout the state and neighboring states. So over the last 8 years, we have followed patients. This is just a sample of the different facilities and whatnot we have. Thank you for your time and allowing me to present a little bit on AMS and OPAT, and Dr. Juskowich is going to give us a little bit more detailed presentation on COPAT to finish up this kind of introduction to our service.
Slides. Yep. Give a talk on complex outpatient oral antimicrobial therapy, or COPAT. I'm the medical director and lead the program with Dr. Sawari, who's here with me. Was very instrumental in establishing and ensuring the program. So you see the name here, and we've talked about renaming the program. So we asked, what's complex about it? So it's really simple, and so we're working on the new name. Right, these are the objectives. So I'm going to go over literature that formed the background of the program, COPAT program, and then focus on service to the state mission. So what is COPAT? So the definition is really using oral antibiotics that achieve high blood levels in place of IV antibiotics. We've added a second component that really is built into COPAT, and that's a shorter duration is better. So looking at both early transition from IV to oral antibiotics and shorter duration of antibiotics. This figure has a spectrum of infectious diseases, and it ranges from the easiest to treat infections with the shortest duration, urinary tract infections. So we have 3 to 7 days, and you could argue 1 day with a dose of fosfomycin now. This transitions all the way to bone and joint infections and endocarditis or endovascular infections at the other end of the spectrum that are typically treated with 4 to 6 weeks of antibiotics. And this is included to just make the point that there's evidence to support early IV to oral antibiotic transition for the hardest to treat infections, bone and joint and endovascular infections. These are 2 landmark studies that really kind of form a foundation that were published in the New England Journal of Medicine in 2019, so over 5 years ago. And the first is partial oral versus intravenous antibiotic treatment of endocarditis. And this study showed that in medically stable patients with left-sided infective endocarditis with gram-positive organisms, IV to oral antibiotic transition after a minimum of 10 days was non-inferior to continued IV antibiotics. 5-year outcome data of the POET trial has also been published. And this really shows that higher survival and no longer-term treatment failure was seen in the group that transitioned from IV to oral antibiotics. So these are the mortality curves, or these are the, I guess, cumulative events and then mortality curves. But really the mortality is better in the patients that were transitioned to oral antibiotics. And this is the next clinical trial. This is oral versus intravenous antibiotics for bone and joint infections. And this showed that when used for complex orthopedic infections, and this was gram-positive, gram-negative, culture-negative, transition from IV to oral antibiotics within the first week was non-inferior to continued IV antibiotic therapy. So since then, there have been many more articles and papers published on this topic. So what is the WVUH COPAT program? So this is an interdisciplinary team, and this was established in 2021 and really matured in late 2022. So it's a newer program versus the OPAT program that had started back in 2017. We provide monitoring and adherence counseling for select patients on oral antibiotics in the outpatient setting. And the goal is really to optimize patient care by doing things like preventing hospital admission and readmission, avoiding need for IV access, and facilitating earlier hospital discharge. And targeted infections are listed here just to show the range of infections. And really, we have everything except for CNS infections on this slide. And that's just because the literature isn't quite there yet. However, in some cases, we do still use oral antibiotics. A little bit more about the program itself. So patients are identified as any patient really being discharged on at least 2 weeks of oral antibiotics. And patients that are willing to take oral antibiotics and also comply with lab monitoring and follow-up calls and visits. So for the process, COPAT consult order is placed, antibiotics are prescribed or dispensed, and the COPAT team calls the patient for medication reconciliation within 2 to 3 days of discharge, and then weekly to discuss adherence, side effects, lab results, and the patient's follow-up in COPAT or IV clinic. Kind of moving on to the third objective is service to the state or outreach. So we broke this down into 2 approaches. So the first is WVU medicine hospitals with ID faculty. And you can see them on the map there. So for this, we implemented a clinical trial, and it's called the COPAT trial. So I'm going to share this as the next slide. It's a poster that Dr. Sawari and I presented at ID Week 2024 in LA. And this is comparing, or the preliminary results of our COPAT trial. So COPAT trial stands for Comparing Oral versus Parenteral Antimicrobial Therapy, our clinical trial. It was designed to demonstrate improved safety of early IV to oral antibiotic transition without compromising effectiveness across most infectious diseases. And it's an open label, pragmatic, randomized controlled trial for patients otherwise receiving at least 2 weeks of IV antibiotics. And those patients are randomized 2-to-1 to receive early PO versus continued IV antibiotics. Two primary outcomes were efficacy equivalence and experimental group safety superiority. And this was conducted across these 5 ID faculty, staff, hospitals, and our WV Medicine health system. And just kind of bringing your attention to our preliminary results here, the main point was that our total adverse event rate in the control group or the IV group was more than 2 times that in the experimental group. And this was primarily driven by line-related events. So these are conclusions of our preliminary results. So early IV to oral antibiotic transition significantly improves treatment safety without compromising effectiveness across most serious infectious diseases. Patients report a strong preference for oral antibiotics. And then at our academic institution and health system, implementation of the COpAT trial accelerated practice transformation among IV providers from earlier IV to oral antibiotic transition. So that was another main underlying reason that this trial was implemented to increase provider comfort levels and change practice. So for the second approach, hospitals in the state of West Virginia without ID faculty, we've developed a COpAT ID e-consult program. This has started with Princeton Community Hospital, where Dr. Sawari and I partnered with Rachel Lester, who's the pharmacist at Princeton. And we started our formal program on March 11th. So from March 11th through December 31st, we served approximately 640 patients. And this included over 100 patients followed through OPAT or COpAT. And over 85% of these were COpAT patients, with really the OPAT patients being those that were on dialysis and could get their antibiotics there. We completed approximately 775 consults and did over 300 follow-up consults. What do we learn from this program? So earlier inpatient transition to oral antibiotics led to earlier discharge. We saw a decreased length of stay and also decreased total antibiotic use. And so we've kind of extrapolated this and we're asking the questions, is this leading to decreased nosocomial bloodstream infections, decreased multi-drug resistant organisms, decreased nosocomial issues like DVTs and pressure sores? And these are just some of the long stream effects that we think can be seen with this earlier transition to oral antibiotics that we'll be looking at. So in summary, early IV to oral antibiotic transition is safe and feasible. It has potential to have significant downstream benefits. And our Princeton COpAT IDE consult program is the prototype to be used for our service to the state mission. Thank you.